is Dr. Burkhard Leeb. Dr. Leeb is the director of the Center for Rheumatology in Lower Austria. He's the president of the Austrian Society for Rheumatology and Rehabilitation between 2008 and 2010. Also, he's a member of and a co-convener of several Euler task forces, including osteoarthritis and gout. He's the chairman of the Austrian Registry for Biologics and the Treatment of Rheumatic Diseases. Dr. Leeb has published more than 150 articles in different journals. Today he will talk about new treatment of osteoarthritis. Please, Dr. Leeb. I forget to mention that this lecture was sponsored by DRP Medochemica.
Okay, thank you, Mr. Chairman, for the nice introduction, and thank you. Thank to the organizers and the sponsors to invite me to come here to this amazing city and to participate in your Congress and to share some ideas about the management, which I consider is a true challenge for rheumatology, namely the management of osteoarthritic patients. And as I learned that diacerin is relatively new in your country, I dedicated the second part of the talk to this drug. I give you all also my disclosures in relation to this drug. You see that there are some clinical trials, that there were some advising activities, and that I had the pleasure to be part of EULA task forces until the year 2011, including the EULA task forces for osteoarthritis. Osteoarthritis, as you know, has an enormous impact on the population. It's a very prevalent disease. About every 10th man and every 5th woman in the world over 60 years suffers from osteoarthritis, and the prevalence increases with age. The leading symptom is pain, but also joint tenderness, the limitation of movement, and the functional impairment, and others. Amongst them, the reduction of the quality of life has an influence upon the patient's fate. And there are other issues regarding the long-term management and the restriction of available pharmacologic agents working in this disease. So I found it relatively interesting when in the year 2011, Hans Bijlsma, Francis Berenbaum, and Martin Lefebvre published their phenotype proposal for patients with osteoarthritis in the Lancet, and it is the metabolic phenotype of patients, the middle-aged patients who suffer from osteoarthritis, often due to mechanical stress, due to adipokine disturbances, due to estrogen or progesterone imbalance, and these are the hard-to-manage patient because there are many issues which relate to their complaints, amongst them overweight, amongst them hyperglycemia, hyperlipidemia, and just to make a sidestep to diacerin, there was a paper published in Diabetes Care in 2011 that in a small sample of Brazilian patients, a better control of type 2 diabetes could be achieved by treating the patients additionally with diacerin. So the management of osteoarthritis, as you all know, is complex, and there are several factors. Above all, the pain level not always relates to the structural damage. The concomitant diseases may influence the pain perception, and also the comorbidities have a crucial impact on the treatment modalities. So we obviously have a need for combination therapy, which does not necessarily mean that you have to combine pharmacological treatments, but you have to combine non-pharmacological treatments, education, and of course also pharmacological treatment. As you see here, American patients suffering from osteoarthritis and hypertension to a significant extent suffer also from comorbidities which have an impact on treatment modalities for osteoarthritis. So we have several treatment strategies to follow: the reduction and the elimination of osteoarthritic pain, the reduction and elimination of the secondary inflammation which relates to damage and relates to arthritic pain, the improvement of functionality, and the inhibition of structural progression of the disease means the inhibition of cartilage degradation, respectively the promotion of rebuilding the cartilage, which is the obviously more difficult task than the other one. So if you have a look on the NICE management plan, you may see the important step 2, the holistic approach and the self-management of the patient, and the important stage 3, the co-treatments, including information, exercise, and weight loss, and then the additional treatment option, which are non-pharmacological, they are pharmacological, or they are even surgical treatments. And we all know that joint replacement makes an ultimate choice for patients suffering from osteoarthritic pain. So what to treat in osteoarthritis? Clinical efficacy, structural efficacy. So the ideal treatment would be somewhere here between. It would be either clinical efficacious and also structurally efficacious, and the worst treatment would be somewhat here. It's like slashing a hammer on the joint. So EULA commissions several task forces for osteoarthritis, and you see the publication dates. Just recently, the EULA recommendations for hand OA were updated. I haven't been part of this task force anymore, but this is an Austrian story and is not of importance for the talk here. What we tried to achieve was a continent-wide consensus. We found the evidence primarily for knee OA, and for hip OA, most frequently combined evidence for hip and knee OA, and only little evidence for hand OA. So the strength of these recommendations, and you always should focus on the title recommendation. It gives you some possibilities to choose your treatment modalities, whereas guidelines are more or less orders which you have to follow. And if you don't follow guidelines, you may face consequences not following them. So the methods used to synthesize the research evidence were robust. It was the Delphi exercise, and we tried to fill the gap between guidelines based solely on research evidence or experts' opinion, and this is the overview. You see non-pharmacological interventions, pharmacological interventions, including paracetamol, topical NSAIDs, non-selective and selective NSAIDs, opioid, analgesics, and Susadua, and the invasive measures like the intra-articular injection, arthroscopy, or joint replacement. There are little differences between knee and hip OA, and the only two differences are the topical NSAIDs are only recommended on the knee level, while osteotomy and joint-preserving surgical procedures are recommended on the hip level exclusively and not on the knee level. Also, SKO published pain therapies for osteoarthritis in an overview like a pyramid. At the basis of the pyramid, the non-pharmacological therapy, and then followed by paracetamol, followed by symptomatic slow-acting drugs for osteoarthritis, including chondroitin sulfate and diacerin, then the NSAIDs, then the narcotic analgesics, and the ultimate measure is surgery, accompanied always by topical analgesics or NSAIDs and intra-articular steroids or hyaluronate applications. And also RC, the Organization for Osteoarthritis Research, developed guidelines. They called it guidelines, which were published by Timothy McEllinton. But if you have a look on the boxes which deal with osteoarthritis with comorbidities, you may have the impression of some poverty. There are not so many possibilities given in those boxes. Coming back to the EULA recommendations, you see that the NSAIDs either non-selective or selective, COX-2 selective NSAIDs, play a certain role in those recommendations, unless they are often not to be prescribed in patients suffering from osteoarthritis, as these patients often suffer from comorbidities which constitute contraindications for the application of those drugs. So in real life, you should use NSAIDs, and we published some German recommendations in Aktuelle Rheumatologie some years ago. You should use the lowest dose possible for the shortest time possible, and should not apply those drugs in patients with risk factors. The reality is that NSAIDs are widely prescribed. They are often prescribed over the counter and often utilized in higher doses than the recommended ones. And the other issue is gastroprotection, which should be co-administered in patients at risk, and especially the over-the-counter treated patients do not receive adequate gastroprotection along with NSAIDs. The other issue are the topical ones. There are limited data. There are some data that topical diclofenac is of equivalent efficacy to oral diclofenac in a 12-week study, but there is always some doubt about the efficacy. Austrian patients love ointments. They love to smear, but it's more or less culturally dependent, I think. And if you use too much of them, there could be systemic exposure due to the topical application of NSAIDs. And the risk of NSAIDs is unambiguously evident. There is little evidence that any NSAIDs is safe in case of cardiovascular terms. There's an elevated risk for myocardial infarction, and there's an elevated risk for congestive heart failure, so that the mortality rate of patients treated with NSAIDs is significantly increased by applying those patients. Are opioids the alternative? So the pros for opioids are obviously more cons for NSAIDs, as you can see. The only drug intrinsic pro for opioids is the lack of the end organ toxicity. That means renal failure or gastrointestinal toxicity is not to be expected with the application of opioids. But there are also cons, and there is a kind of a drug addiction. There are adverse events. Patients treated with opioids, they tend to have a higher frequency of fall, and there is also lack of efficacy. And as what we can see here in this meta-analysis by Daniel Solomon, that the red line, and the red line are the opioids, they are always the worst tolerated drug in comparison to selective or non-selective NSAIDs. May paracetamol, acetaminophen, an alternative with respect to its effect size, and due to our experience in Austria and in Northern Europe, we are not very convinced that paracetamol is an effective alternative in treating osteoarthritic pain. In this study, it was least effective with a small effect size, and celecoxib as a selective COX-2 inhibitor was slightly more effective. Does the dosage of intra-articular corticosteroids matter? It does not, according to this trial published in the Journal of Rheumatology in 2015. There was no difference if you apply 80 or 40 milligram of triamcinolone intra-articularly into an osteoarthritic knee. So there are other treatments like the serotonin norepinephrine reactive inhibitors, which are part of the ORC recommendations and also part of the ACR recommendations for osteoarthritis. There are randomized controlled trials out that duloxetine is capable of ameliorating pain to a significant extent in patients with osteoarthritis. maybe also for the improvement of mood, and or also others of these serotonin or epinephrine reuptake inhibitors are investigated for their capability to reduce pain in patients with osteoarthritis. Antibodies to nerve growth factor have been shown to be an effective pain treatment, with the caveat that osteonecrosis did occur to a relatively frequent extent, and this problem should be solved before those innovative therapies should come to the market. So, coming to the second part of my talk, which will deal with the symptomatic slow-acting drugs in osteoarthritis, and in particular with diacerin, I just show you how long we study those drugs. In 2000, we published a meta-analysis about chondroitin sulfate in the Journal of Rheumatology, revealing a small positive effect on pain and function on the basis of 8 trials. And then later in the first decade of this millennium, we were part of a trial which dealt with the structural efficacy of chondroitin sulfate, revealing an interesting and intriguing result that patients with a higher BMI had a better efficacy regarding structural damage than patients with a lower BMI. This hasn't been repeated since then, but it's at least anecdotally interesting that it could have been an advantage to have a higher BMI. For me, it's somewhat calming me down because obviously I'm in the range between 25 and 30. So diacerin, as you may know, is an anthraquinone derivative inhibiting interleukin-1 in vitro. It's completely metabolized to RAIN, which is the active metabolite, and this is the chemical reaction, which is a deacetylation, leading to the RAIN as the active compound, and this is the plant I show you here diacerin is originating from. It is part of the EULA recommendations, as is part of the ORC recommendations, and it's also part of the SKO recommendations from 2016, where SKO recommended it as a first-line pharmacological background treatment for osteoarthritis, and these are the 2 respective publications dealing with this. There are several safety and efficacy studies, and if we go through them very briefly, you may read in bold letters the succus of all those trials. In 1994, it was found superior to placebo for pain relief. In HIP-OA, it was found superior to placebo improving pain. In NE-OA in 1998, in 2000, it was also in 2006 found comparably efficacious to diclofenac in NE-OA, and this is the, I would say, most interesting trial performed by my friend Karel Pavelka from Prague, because he had the primary endpoint in this trial 5 months after treatment start and 2 months after stopping the treatment with diacerin, because the target of this trial was the proof of the carryover effect of diacerin. There was a almost simultaneously performed trial in Thailand comparing diacerin and piroxicam, where diacerin proved to be similarly efficacious than piroxicam. So this is the primary result of the Pavelka trial, which was published in Arthritis and Rheumatism, and you see that in week 24, diacerin in blue is statistically better than placebo in green, whereas diacerin treatment had been stopped 8 weeks before. It was obviously there were obviously some restriction of tolerance for diacerin in this trial, primarily for loose stools and diarrhea and abdominal pain, but all those side effects were reversible and did not lead to a treatment stop. So in conclusion, in this first study with the Cisadoa, where the primary endpoint was 2 months after the cessation of treatment, it could be proven that there is a significant carryover effect exerted by diacerin at month 5 after the beginning of the treatment. And also, if you apply the OMERACT-ORC 2004 responder criteria, and you see this is a two-step approach, if you have a high improvement in pain or function and an absolute change of more than 20 on the visual analog scale, you are regarded a primary responder. If you are not a primary responder, but show at least improvement in 2 of the 3 following points, namely pain, function, or patient global, you are also regarded a responder. And in the Pavelka trial, 65.8% of the diacerin-treated patients responded, while only less than 50% of the placebo patients responded, and this holds true for the Lutheran Node trial. The application of the ORACI responder criteria in this trial revealed that at month 6, almost 100% more of the diacerin-treated patients responded to the drug in comparison to piroxicam. So the revealed effect sizes of diacerin are small. This is 0.24. If you take into consideration that the effect size for NSAIDs versus placebo is 0.29, and above all, the effect size for paracetamol versus placebo is 0.14, you may see that these effect sizes can be regarded clinically relevant. And this also had been demonstrated by the responder calculation applying the ORC responder criteria in the post hoc analyses of the Pavelka study or the Luciano study. Very recently at the EULA 2018, a Pakistani trial was presented comparing the effect of diacerin versus a combination of glucosamine and chondroitin on disease progression and measures of function in person, and the patients were treated either with 100 milligrams of diacerin for 2 years, of 1,200 milligram twice daily for 2 years of a combination glucosamine and chondroitin, or with placebo. And in Amsterdam, the results for the year 1 and the year 2 were analyzed, and the analyses were presented, and it showed a significant improvement in the ability to work and other physical activities compared to the groups treated with chondroitin glucosamine combination or with placebo. The instruments applied to measure improvement were the WOMAC, the pain, stiffness, and physical functioning. Diacerin is the only drug revealing positive structural efficacy on the hip level. This is the pivotal ECHO-DIA trial, which was performed by Maxime Dugadeau from Paris, and it showed over 3 years a superiority of diacerin regarding structural damage in comparison to placebo. Several meta-analyses were performed, amongst them ours in 2006, and 2 from Brazilian colleagues, namely the group around Fidelix, one of Bartels, and a Swiss one in 2011 and one in Thailand. And these are very briefly the result we found and published it in the Archives of Internal Medicine. We found the superiority of diacerin with respect to pain in comparison to placebo, and a similar efficacy of diacerin with respect to pain in comparison to NSAIDs. And this was also the case with Bartels, who proposed diacerin as an alternative for patients where non-steroidals could not be given for the presence of contraindications or other issues. Bartels found the same with respect to the tolerability of the drug, namely that the drug is worse tolerated than placebo with respect to diarrhea and to the withdrawal of the drug. What we found in our meta-analysis additionally was that the drug is similarly tolerated than NSAIDs in those studies. An interesting Canadian observational trial was presented in 2014, revealing the common application of the combination of diacerin with NSAIDs and the benefits patients can achieve by being treated with the combination of NSAIDs and diacerin. So these are the last, most recent conclusion. PANOVA in drug safety concluded that there's a role of diacerin for the treatment of knee and hip OA, and I already mentioned the SKO recommendations, which positions diacerin as a first-line pharmacological background treatment of osteoarthritis. There are some treatment trials ongoing, and we are part of the trial where the 400 patients are observed in as a non-inferiority trial in comparison with celecoxib. So in conclusion, several societies recommend the application of diacerin. The majority of trials and meta-analyses have shown a positive effect on pain. The European Medical Agency reviewed diacerin some years ago and found that it's an interesting option in the physician's armamentarium for treating OA. The benefits of diacerin, according to the opinion of the EMA, outweighs the risks of the application of the drug. The effect size is small but well established, and the symptomatic efficacy is comparable to NSAIDs. It has a carryover effect which is not exerted by non-steroidal antirheumatic drugs. Obviously, there are some costs for the application of diacerin, and the most frequently reported and dose-related side effect is diarrhea or loose stools, as common mild skin reactions, and very rarely hepatobiliary disorders. Diarrhea is common, and diacerin should be avoided with a known propensity for diarrhea, but especially older ladies in Austria suffer from constipation, and therefore diacerin could be an ideal drug for them treating osteoarthritic pain. Often urine discoloration is reported, but this effect is due to the elimination of the Rein metabolites via the urine and has no clinical significance. It disappears by intake of enough amount of fluid daily. What can ameliorate the situation of osteoarthritic patients in the future? There are trials with metalloproteinase inhibitors. There are some little trials with biological IL-1 inhibitors. There are studies dealing with the inhibition of aggrecanase 2 via ADAMS5. There are studies, and most recently were presented at the ACR, a trial which dealt with the inhibition of sclerostin. Anti-resorptive agents have been trialed, and also mesenchymal stem cells. But I hope we will have in the future a different situation, that we can solve the challenge for rheumatology in the future, because if you look at this research agenda from the year 2003, it's even in the year 2018, it's relatively modern, and many of these research points haven't been solved yet. So having said this, I thank you for your attention.
Thank you, Dr. Leeb, for updating us about the treatment of osteoarthritis. Is there any question or comment?
Please. Please, can I ask you about your experience about hyaluronic acid and PRP intra-articular in the knee?
Hyaluronic acid is, it was part of the study with acetaminophen, is a good option for treating patients suffering from osteoarthritis with injectable joints. So if the joint is more or less easy to inject, I would propose to use hyaluronic acid. I would not propose to use hyaluronic acid in the thumb,
Yes.
as some colleagues do, because my patients won't stand it. But for the knee joint, for example, the shoulder, for example, it can be an option.
Thank you. Dr. Marwan.
I'm sorry to reiterate his question. This is an important thing to answer because hyaluronic acid in this country is not available on the National Health Service, and it's expensive. So is there any evidence for the effectiveness of hyaluronic acid in osteoarthritis of the knee?
There are trials which prove the efficacy of hyaluronic acid, but there are also negative trials for hyaluronic acid, and the situation in my country is as it is in yours. It's not reimbursed by the social insurance companies, and patients have to buy. But I think if patients can afford it, it may constitute an option. But I think the majority of the trials is positive. The other issue is in Austria, it's relatively expensive for the social insurance companies, and they are somewhat afraid to open the door.
It's positive whatever the stage of osteoarthritis, because you are generalized now.
Well, the
for hyaluronic acid.
The trials were not performed in end-stage patient, and I would not recommend to do it in eight-stage patient unless you perform an ultima ratio therapy. So I think there should be some target for hyaluronic acid, and this is the articular cartilage.
And what
I
about,
think it's more than a lubricant.
and
I
what
think
about the rich plasma, Dr. Julius asked you the question.
It's reported to be positive. I have no personal experience with it. It's reported, and to my knowledge, is not performed in Austria.
Thank you.
Okay, thank you, Dr. Leeb. Thank you very much.
Thank you very much.